Hello again. I wanted to now introduce our second speaker, who is Tamara Hoffman. She will be providing a 2-hour continuing education course on dental radiography for dental professionals. Professor Hoffman graduated from UMKC School of Dentistry with a bachelor's degree in dental hygiene in 2005. And she has been a full-time faculty member at the UMKC School of Dentistry since 2008 in the radiology department as clinical instructor, overseeing the diagnostic quality and interpretation of the students' radiographs. She holds several board positions, including past president of the Dental Hygiene Alumni Association, president of the Sigma Phi Alpha Honor Society, representative for United Way and the Alumni Association, and vice president of events. She has conducted interviews for both UMKC dental and hygiene acceptance committees, and she serves as an interprofessional experience facilitator for student impacts. Professor Hoffman has received 7 Teaching and Excellence Awards from her students. She brings a detailed understanding of the importance of diagnostic radiographs and years of experience, culminating that knowledge into a teaching method tangible by future dentists and hygienists. Welcome, Tamara, and thank you for speaking. Enjoy.
Good morning. Thank you so much for the great introduction, Dr. Howenstein, and thank you to the Sioux City Dental Society for having me here with you this morning. When I was approached earlier in the spring about speaking for your guys' conference, I was really excited. I was really nervous at the idea of presenting in front of such a wonderfully great group. I was given pretty much free rein to present whatever information I felt would be most important for those practicing in your communities. So I went through all of the information that I share with our dental and dental hygiene students on a daily basis. And then I decided to come up with this not terribly exciting title, but we're going to go over the reiteration of the importance of taking quality images safely when necessary. So just a few disclosures. There is no intent on advertising any product brands in this presentation. Much of this presentation is going to be derived from teaching materials that we use for our dental and dental hygiene students. And then the information and images within this presentation are not for sale or distribution, please, outside this presentation. They're merely for discussion. So the most important things that I try to instill in our students when they're coming through our department are the armamentarium, the different types of devices and instruments that they're going to use in order to capture good radiographs. Infection control, the importance of maintaining good infection control when you're taking radiographs. Proper technique, being able to recognize diagnostic images, as well as recognizing when there are errors within our technique and what we need to do to correct those. And then last, but certainly not least, are the guidelines for prescribing the radiographs, knowing when to order radiographs and what type of radiographs to order. So first off, to get a little bit of discussion going, because I'd like to get some feedback from all of you, in your practices that you are at, the majority of offices were using digital radiographs. But I would like to know if you're using the digital hard state sensors or if you're using digital phosphor plates. So if you wouldn't mind just sending in a quick message to me, letting me know what it is that you're using in your offices. Basically, both types of devices offer a variety of pros and cons in their functionality, their cost, their ease of use and comfort for patients. So at the School of Dentistry at the University of Missouri, Kansas City, where I'm from, we primarily teach our students both devices. We have them using the solid state sensors as well as the PSP phosphor plates. So when you're taking intraoral radiographs, as we all know, there are multiple devices and holding devices that we can use for placement of these radiographs. So at the school, we've been teaching our students primarily how to use the XCPs, the X-ray cone paralleling devices. Recently, we started showing them how to use the OR, the all-in-one. No matter what device you have, it's important that you find one that is compatible for you and your patients and what's going to be the most cost efficient, but yet give you the results that you need. You may be using these styrofoam staves. Those are great. They're nice and comfortable for most patients. If you have issues with patients who have got maybe some fractures on the incisal or occlusal edges, when they close down, that surface area of the occlusion is able to slip right into that styrofoam, ensuring that your film and your bite place will not be shifting around within the mouth. Are you using the bite wing sticker tabs for when you're taking your bite wings? Are you using the XCPs? Something that's important to consider when you're using the XCP for bite wing, and I always remind this to our students because they get so excited about XCPs and how it just does everything for us. But you always have to take into consideration that the XCP just guarantees that your beam hits your film, but the target of the teeth, that horizontal angle that's required to get the contacts open, is not always considered. So you've got to take that in consideration in making sure that you're aligning your film parallel to the teeth. Then we've got the armamentarium or bite block devices for the sensors. Are you using the snap arrays or are you using the XCPs? And there's various different types and styles of them. These are just some of the ones that we're working with daily. So things to consider when you're taking your radiographs and determining what type of bite piece or what type of receptor device, being either the phosphor plates or the solid state sensors, that you're going to use. Consider the receptor placement, any elongation or distortion that could happen, and patient comfort. When it comes to receptor placement, consider the mouth that you're working in. What challenges or obstacles might we have? Do we have a patient who has mandibular tori? Are we going to be able to comfortably sit our sensor and rest it right between those two bony tori? What about a lingual foramen? A lingual, oh gosh, I'm totally drawing a blank. A lingual attachment. Perhaps they're a little bit more tongue-tied and we can't quite get the sensor to place right behind there. Or perhaps we have the patient who comes in and they've got the tori palatini or large exostoses. How are we going to manipulate and place that sensor or that phosphor plate so that it fits in there? Perhaps a phosphor plate is going to be best for the mandibular tori, especially the mandibular tori that almost meets at the midline of the floor of the mouth. What if we're trying to get a canine PA and our XCP bite piece just doesn't quite reach it, allowing the film to be way back behind? Or maybe we need to switch from a size 2 film to a size 1 in order for it to fit. Or if we're working with that tori palatini, do we need to place our receptor device on the opposite side of the palate in order to capture the desired teeth? How about this patient that comes in? Now we've got to take some PAs on this one. Or maybe here, where we've got an open anterior bite, or we've got the open posterior bite. If we're needing to take bite wings of an open posterior bite area, how are we going to make sure that those teeth are able to occlude on our bite block to ensure that that receptor device stays where we've placed it to capture the areas of concern? Or if they've got that open anterior bite, are we going to have an XCP that's going to be thick enough in order to allow them to fully occlude and maintain the placement of the device? How about the patient that comes in with limited opening? We've all seen it. We're trying to get our XCP inside of their mouth. We just can't manipulate it enough. The patient's in pain, but we've got to try to get that in there and manipulate it so that way we can capture the area that we're looking for. Can we change the size of our phosphor plate maybe to fit in there? Do we need to switch from the sensor to phosphor plate? Or maybe we need to use a sensor with just the snap array. What if we've got a patient who's got that significant amount of overjet and they're having difficulties biting on our bite block? How can we maneuver and manipulate it so that way they can fully occlude and our sensor is not moving around? Or what about the patient who simply has the overbite and we're trying to get the anterior PAs? Or what if we need to get some posterior bite wings and we're not quite able to reach the distal of the canine? How about patient comfort? We've all had those patients in our chairs, the ones who start to gag. Nobody likes to have x-rays. They're not usually comfortable, but it's worse when we've got a patient who feels like they're going to throw up at the thought of taking x-rays. So down at the school, we like to teach our students that there are definitely some techniques that we can teach our patients to use that might help them get through this uncomfortable situation, but help ensure that we get diagnostic radiographs. Have you tried the humming trick? The patient may feel a little bit crazy, but when you've got that XCP or that sensor in their mouth and they're doing the whole gag response, just have them hum while they're doing that. That way they're focused on that. Because as we all know, when it comes to a patient who has that extreme gag response, it comes down to distraction. We need to have their mind thinking on something other than what we're doing in their mouth. Have you tried the old-fashioned table salt trick? As long as you've got a patient who doesn't have uncontrolled hypertension, this is another great trick. Just have them stick their tongue out, look up to the sky, sprinkle a little bit of salt on their tongue. We always have them close their mouth right away so they get that taste in their mouth and they're focused more on that. Then have them open up and go right on in with your sensor and start getting those radiographs while they're thinking about that taste in their mouth. How about giving them something to squeeze? Having them engage and activate different muscles or extremities kind of has them think about that. You can take a glove and simply blow it up if you're not short on gloves right now. Or just get a little squeezy ball, a little stress ball, just something for them to focus on. Sometimes we'll have them raise their leg, kind of tense their abs. That way they're focused on that. And then as a last result, last remedy, and for a lot of our dental assistants probably know when you're taking impressions, gagging is not a great thing either. Sometimes you just got to go to some lidocaine spray or a topical anesthetic, and that will help them get through it. Just spray it along the lingual surface of the tongue area or at the hard palate, soft palate area, and that'll be enough to get in there and get the radiographs taken that you need. Patient comfort when they're having pain. If it's a toothache, what we want to try to do is avoid having them bite directly on that tooth. But if it's the film, the plate, or the sensor that are the most uncomfortable, as we could see in this patient, when we've got this large mandibular tori, or we've got a really wide maxillary ridge, or a shallow palate, or just a really narrow arch, sometimes we need to cushion those devices. If you've never seen them, there are little padded styrofoam sticker cushions that you can put on your different films and sensors. That way it just pads it and makes it comfortable enough that those corners and edges aren't going to cut into the patient's tissues, making it 10 times more undesirable to get radiographs. As we've all learned, if you can take that extra step to make a patient feel a little bit more comfortable, reassuring that we know that they're uncomfortable, we want to try to do something about it. We're going to put this little cushion on there, or we're going to readjust our positioning. That way it's a little bit more tolerable for you. That can go a long way. Patient compliance, as we know, is huge to our success, especially when we're trying to get them to brush and floss. So infection control, like every other aspect of dentistry, of hygiene, of our lives right now, is all about infection control, keeping ourselves safe, keeping every area is clean and reducing the likelihood of contracting something, especially like COVID right now. So the CDC has become a very high topic place for recommendations for our infection control. So I definitely encourage you to make sure that you're keeping up with the CDC recommendations and guidelines. But let's review our standard precautions that we should always be considering in the dental office and dental settings. Our hand hygiene. Make sure that we are washing our hands as frequently as we should before and after patients, scrubbing for that recommended 20-second time. The use of personal protection equipment looks a little bit different for some of us right now. We're wearing different types of masks and face shields. How about our respiratory hygiene? Making sure that we're using proper coughing etiquette, sneezing etiquette, cleaning afterwards, making sure that we're covering our coughs. Of course, sharp safety, making sure that we're practicing the correct ways of managing that. Our safe injection practices, our sterile instrumentation and devices, especially when it comes to our X-ray devices, and clean and disinfected environmental surfaces. So infection control, some of the key recommendations for sterilization and disinfection of patient care devices within the dental settings. So try to keep in mind those areas that this would impact when it comes to what you're using for taking your radiographs. Making sure that you clean and reprocess or disinfect or sterilize the reusable dental equipment appropriately before use on another patient. So if you're using a bite piece for your panoramic machine, are you burying it or do you have to sterilize it in between patients? Clean and reprocess reusable dental equipment according to manufacturer's instructions. If the manufacturer does not provide such instructions, then the device may not be suitable for multi-patient use. So know whether or not your XCP bite pieces should be sterilized or if they should be barriered, or if disinfection is simply enough. Have the manufacturer instructions for reprocessing reusable dental instruments and equipment readily available, ideally in or near the reprocessing area. Make sure everyone in your office who is taking radiographs is familiar with the proper ways to sterilize and clean these devices. Assign the responsibilities for reprocessing of dental equipment to the dental health care provider with the appropriate training. And be sure to wear the appropriate PPE when handling and reprocessing contaminated patient equipment. Even though you're in your cubicle and you're going to quickly take a radiograph, keep in mind all the things that you're touching. Know the areas you've contaminated. Should you be burying those areas or is simply disinfecting enough? Make sure you know the kill time for your disinfectants. That way it's appropriately killing off those bacteria. Use mechanical, chemical, biological monitors according to the manufacturer's instructions to ensure the effectiveness of the sterilization process. And maintain sterilization records in accordance with state and local regulations. Establish policies and procedures for routine cleaning and disinfection of environmental surfaces within the dental care settings. Be sure to use surface barriers to protect those clinical contact surfaces, particularly those that are difficult to clean. So whether it be a cord for your sensor, whether it be your apron that goes on the patient, make sure you're covering and cleaning the right areas. If you've got a tube on your x-ray unit that has any kind of depressions in it or cracks, make sure that those areas are covered properly. And change the surface barriers between patients. Clean and disinfect clinical contact surface areas that are not barrier protected with an EPA registered hospital disinfectant after each patient. Again, knowing the kill time. If it requires 2 minutes, you got to make sure you saturate it and leave it for the 2 minutes. Use an intermediate level disinfectant. That's got to be tuberculocidal claim if visibly contaminated with blood. Say that one twice. Select EPA registered disinfectants or detergents and disinfectants with label claims for use in the healthcare settings. And be sure again to follow the manufacturer's instructions for the use of these cleaners and the EPA registered disinfectants. Make sure you know the amount that you should be using, the dilution percentage involved, and the contact time or safe use and disposal of those products. So our PPE. Like I said, it may look a little bit different now, but as we all know, we are working within the setting where we are right there with those aerosols from the oral cavity. So we want to protect ourselves as best as we can. So this is a little bit of an idea of how it looks down at our school with our students. So pre-COVID, we wore the gowns, obviously the ones that are water resistant. They've got their gloves, they've got their safety glasses, and their regular mask. These were just like a stage 2 mask. Now, post-COVID, our students are all still wearing the same PPE gowns and gloves. They can wear their safety glasses or their loupes, but they're also wearing face shields. And everyone in our clinic is now wearing an N95 mask. And if it has the release valve on it, we have to wear surgical masks over those. So things to consider, which I'm sure that you have already taken into consideration, and you guys have already made changes within your office as to what protocol needs to be. So I definitely want to emphasize again, radiation safety. This is something that we really have to remind ourselves that we're dealing with ionizing radiation and that we want to protect not only ourselves, but our patients as well. So we need to continue to make sure that we're using lead aprons, and it's recommended that they have a thyroid collar. Because remember, we want to protect those areas that are highly sensitive to the ionizing radiation, our reproductive system, as well as the thyroid. So another way to protect our patients from excessive radiation use is the collimation or the cone device that we use. Some units have rectangular cones and some have the round cones. I know when I was in private practice, all of the units we ever had were round. But at the dental school, we teach our students to use the rectangular ones. It drastically reduces the amount of exposure. So it's something to consider. So you've got your round cone or your circular cone, and then you've got your rectangular cone. You've got a long collimator and a short collimator. Take a look and see which one you have, because there is a big difference between the amount of scatter radiation that can be seen. Here in this diagram, it's going to show you the scatter radiation reduction of up to 70% simply by using the rectangular cone. You can see how it collimates it, and it guides that scatter radiation to more of a focused point at the sensor. Or here in the round cone, we can see that the radiation is penetrating the sensor. But what we've learned here is 90% of photons from the beam are absorbed by the surrounding tissues, leaving only 10% of that receptor actually receiving the ionizing radiation. This diagram right here, I really like, and I love to share with our future practitioners, is it gives you an idea of the amount of ionizing radiation we create in dental radiography on the left, and compared to the amount of environmental radiation which one receives through just daily activities. So you can see down here at the very, very bottom, you can see where a patient may receive 4 bite wings. It's close to the comparison of the amount of scatter radiation or radiation that was received just from our environment within one day. And you got to remember that's radiation coming from within the ground, from the sun, from any of our electronic devices, from our food, and so forth. A patient who comes in and receives a Panorex, it's going to be fairly close to the comparison of a 5-hour airplane flight. And then a patient who comes in and they receive a full mouth survey or a CBCT is going to be receiving a similar amount of dose to that they would receive from receiving a chest radiograph. So things to consider is we are still dealing with ionizing radiation. It is significantly reduced in being in the dental profession. We just don't require as much to penetrate the tissues of the oral cavity, but we still want to be responsible with that radiation. As a clinician, it's still very important that we practice not only social distancing to prevent COVID, but also stay that 6 feet away from the source of the radiation to protect yourself. If you're not able to get 6 feet away, try to have a lead apron for yourself to wear. Be sure to protect yourself. If you don't have enough distance, perhaps one of these lead walls on wheels might be something that you might need. Or see if you can just get some lead plating put in on the side of the wall or around a corner to protect yourself. Just get that 6 feet of distance. Nomad. If you find that your office is using the Nomad, make sure that those who are using it have been properly trained. Because anytime we're dealing with radiation, you've got to know the device's limitations and the areas that you need to be more concerned in protecting yourself as well as the patients. Anytime we're dealing with and creating radiation, we need to take into consider the responsibilities that will come with that. We need to know if our state requires us to register the devices that we use. Do you have a radiation safety officer within your practice? Someone who can do the monitoring and make sure that everything is running properly. Storage. Do you have a good protocol system for storing these devices and keeping them safe? Unit inspections to make sure that there are no cracks or flaws within the device. Quality assurance. Who helps to make sure that those radiographs that are being taken by all the different staff and auxiliary and hygienists in your office are getting the right images, diagnostic images that the doctor can fully diagnose off of, as well as the ones that are going to be sent off to insurance. We've got to make sure we're taking good radiographs. That way we've got clear information as to why a treatment has been recommended. Operator training. Is everyone properly trained in taking radiographs? Infection control. Are we watching and making sure that everyone is following the recommended policies within your office? As well as radiation protection, making sure that everyone is doing their best to protect the patients as well as themselves. Dosimetry recording. Do you have dosimetry tags in your office that your folks wear or you have mounted within the areas that one will stand to keep their distance from the radiation? Does that happen? As well as reporting lost or stolen equipment. If a device is missing or a sensor is lost or stolen, make sure that you've got record of that and you've reported it, because some state agencies require that. It's always important to know the guidelines for taking radiographs within your state. So I've provided the websites for each. Some states require that any dental assistant who takes the radiographs is registered by the board as a dental radiographer. Be sure that you know what the guidelines are for your area and make sure that everyone is within compliance of that. Here in the state of Missouri, you don't have to have a certification or degree or anything for taking radiographs. So a dentist can just bring in anybody, a patient, and teach them how to take radiographs. But we want to try to oversee that. We want to make sure that everyone understands the importance and respects the radiation that we are creating. So let's talk about proper technique. Working with my students, I get a little bit of grumbling from the dental students because they don't plan to take radiographs when they graduate. But we ensure that they need to know what is expected to be seen in a radiograph, what they need to see in order to make a good diagnosis, as well as if there's any technique errors. We need them to be able to recognize if there was some distortion and know what needs to be done to correct it. Our hygienists, as well as the dental assistants that come to us from a community college nearby, are really great about getting excited about getting in there and taking good radiographs. We all know how stressed we get when we've taken radiographs and we haven't yet seen how they've come out and we're a little bit nervous. So full mouth for us down at the School of Dentistry looks like 10 films. We have them take 4 molar periapical radiographs, 4 premolar periapical radiographs, 2 molar bite wings, 2 premolar bite wings, 4 cuspid periapical films, 1 maxillary central PA, and 1 mandibular central PA. Now this can vary from office to office, taking between 16 and 20 radiographs. So let's go down and review what we want to look for in each and every radiograph as we're going through. The maxillary molar is typically taken with a size 2 film horizontally. You want to be sure to align the anterior border of your film, that is with the contact between the second bicuspid and the first molar. Placing the film in the midline of the palate, parallel to the long axis of the teeth and lingual surfaces of the teeth. The characteristics you're looking for in a molar PA are you want to see the contacts of the molars being open. You want to see 2 to 3 millimeters of bone visible beyond the apices of a molar PA. It's really important. If you're taking a PA for the doctor and it comes up on your screen and you're squinting and you're trying to strain to see if you've got the apex, you probably didn't get it because you want it to be clear that you've got 2 to 3 millimeters of bone well beyond those apices. Is the tuberosity area shown? Making sure that we can see that third molar area, to see if there's a third molar that is impacted, or if it's tilted, or if it is impacted upside down. You want the occlusal plane to be parallel and slightly above the lower border of the film. And you want the cusp tips, the height of the cusps buccally and lingually, to be superimposed. Obviously, that's not always going to be the case when you're taking a maxillary PA because we have the hard and soft palate there. But try to get that film or that plate as more in the middle of the palate as you possibly can, and get that film to stand as parallel to the teeth as you can get it. That way you'll have minimal distortion. The maxillary premolar film is typically a size 2 film taken horizontally. You want to align the anterior border of the film so that it covers the cuspid, so distal contact of the cuspid will be visible on the processed film. Place the plate in the midline of the palate so that it is parallel to the long axis and lingual surfaces of the teeth. So again, what we're going to be looking for are contacts open between the premolars, 2 to 3 millimeters of bone well visible beyond the apices, and the distal contact of the canine should be open and visible. Wanting the occlusal plane to be slightly above the lower border of the film, and the cusp heights to be similar to one another between the buccal and lingual. Maxillary cuspid films. Typically for a canine radiograph, we're going to use a size 1 film vertically. This is how it should look standing upright and parallel to the long axis of the tooth. You want the contact between the cuspid and the lateral centered on the film. Directing the beam to pass right between the mesial contact of the cuspid so that that contact will be visible on the processed radiograph. Place the film posterior enough in the mouth so that the patient is biting on the end of the bite block away from the film. This might be tricky if we have that patient who has the open anterior bite. So the characteristics we're going to be looking for in a canine radiograph are going to be mesial contact of that cuspid being nice and open, the contact between the cuspid and the lateral centered on the film, 2 to 3 millimeters of bone well visible beyond the apex of that cuspid. And then we want to see that the incisal edge of the tooth is slightly above the lower border of the film. That way, if there are any incisal fractures or any type of abrasion and fracture, we'll see that. The maxillary central and lateral incisor film is typically a number 2 film vertical. Again, if you have a patient who has that really narrow arch and a size 2 is simply too wide, or that size 2 sensor is too wide, see if you can go down to a size 1. You want to place that film parallel again to the lingual surfaces of the teeth and align the central contact with the center of the film. Direct the beam to pass right through that central contact so that the contact will be visible on the processed film. Place the film in the far posterior of the mouth so that the patient is able to fully bite down on the bite block. That will also help with getting the film to be parallel to the teeth. Again, we want the contacts between the centrals to be open and centered on the film. We'd like to see 2 to 3 millimeters of bone well beyond the apices of the central and lateral incisors. And we'd like for that incisal edge to be the contact, between the 2 central teeth should be visible on both the right and the left central and lateral radiographs, with the incisal edge of the teeth being slightly above the lower border of the film. Mandibular molar PAs typically are a size 2 film horizontal. Align the anterior border of the film so that it is with the contact between the second bicuspid or the second molar, or second premolar, and the first molar. Place the film so that it's parallel to the lingual surfaces in the long axis of the teeth. And then the tongue should not be between the film and the x-ray source, or it'll be visible as the shadow on the lower edge of the film. So be sure when you're placing your film in there for mandibular posterior PAs as well as premolars that you're getting the tongue out of the way. Slide that film down between the tongue and the lingual ridge of the teeth. That way you don't have any distortion from that tongue. We want to see that the contacts of the molars are open, along with the 2 to 3 millimeters of bone well beyond the apices of the molar teeth. That retromolar pad back here should be visible so we can note if there are any third molars and what position that they are in. The occlusal plane should be parallel and slightly below the upper border of the film, with the cusp tips being superimposed upon one another. As you can see over here on the right, you've got your cusp here and your cusp on this side. This would probably be the buccal side. They are about the same height. That way we're shooting that tooth very perpendicular. Mandibular premolar film is standardly a size 2 film taken horizontally. You want to align the anterior border of the plate to cover the cuspid so that the distal contact of the cuspid or canine will be visible on the processed film. Place the film so parallel to the lingual surfaces and long axis of the tooth. The tongue should not be between the film and the x-ray source, or it will be visible on the shadow or the lower edge of the film. Again, watching to make sure that the contacts of the premolars are all open, with the 2 to 3 millimeters of bone beyond the apices. The distal contact of the cuspid should be open and visible, and the occlusal plane parallel to and slightly below the upper border of the film. The cusp tips, again, should be superimposed upon one another at the same height. The mandibular canine, size 1 film taken vertically, placing the film parallel to the lingual surface and the long axis of the teeth. This is pretty easy to do considering there's no hard palate down on the bottom. You've just got that soft floor of the mouth. So make sure you move the tissues, the tongue out of the way, and have them fully occlude. Align the midline of the cuspid with the center of the film and direct the beam to pass through the mesial contact of the canine so that the mesial contact will be visible on the processed film. Place the film in the floor of the mouth so the patient is biting on the end of the bite block away from the film. If there were tori in there, you would want to try to extend towards the back of the mouth. That way you're away from and behind the tori. So the characteristics you're going to be looking for in that canine PA are a mesial contact of the cuspid should be open. The cuspid should be well centered on the film vertically, with 2 to 3 millimeters of bone visible beyond the apex. And the incisal edge of the tooth should be slightly below the upper border of the thumb. Mandibular central and lateral incisors. Standardly a size 2. Again, if you've got a patient whose mandible is really narrow or there's tori, you might need to switch to a size 1. Place the film parallel to the lingual surface of the teeth and the long axis of the lower 4 incisor teeth. Align the central contacts with the center of the film. Direct the beam to pass through the central contacts so that this contact will be visible on the processed radiograph. Place the plate in posterior of the mouth so patient is biting on the end of the bite block away from the thumb. Whether you're using plate or the hard state sensors, you want to keep this in consideration. You want to see that the contacts between the centrals and laterals are open and centered on the radiograph, with 2 to 3 millimeters of bone visible beyond the apex of the centrals and laterals. The incisal edge of the teeth should be slightly below the upper border of the film. Mandibular molar bite wing film. For adults, those are typically going to be size 2 films. If you have a child with primary teeth, you'd probably want to switch to a size 1 sensor or plate. And bite wings, again, just so you know, can be taken vertically or horizontally, depending upon your patient's periodontal status. You want to align the anterior border of the film with the contact between the second premolar and the first molar. Place the film in the midline of the floor of the mouth so that it's parallel to the long axis of the teeth and the lingual surfaces. The tongue should not be between the film and the X-ray source, or it will be visible, causing a shadow at the lower edge of the film. Regardless of which instrument you're using, the tube should be approximately a 10-degree positive angulation so that there will be an equal distribution of the upper and lower teeth on the film. Contacts of all the molars should be open and visible. The occlusal plane should be parallel to the horizontal or vertical center of the film with equal distribution of upper and lower teeth. The two things you're always looking for when you're taking a bite wing radiograph are open contacts and the bone levels. Mandibular premolar bite wing films are also typically a size 2 plate, unless you have a patient with primary teeth and you may want to use a size 1 or a 0 for the little ones. Align the anterior border of the film to cover the cuspid so the distal contact of the canine will be visible on the processed film. So again, when you're doing a premolar bite wing, that is where the dentist or hygienist want to see the distal of the canine and then in between each of those premolars. Place the film in the midline of the floor of the mouth so that way it is parallel to the long axis of the teeth and the lingual surfaces. Again, the tongue should not be between the film and the source of the exposure. Regardless of what instrument you're using, again, make sure you have that 5-degree positive angle. That's what's going to separate the occlusal surfaces of the maxillary and mandibular teeth. Looking for the contacts of those premolars to be open, we want the distal contact of that canine open and visible, and the occlusal plane should be parallel to the horizontal or vertical center of the film with equal distribution of the upper and lower teeth. So again, bite wings, we want to see open contact and we want to see bone levels. If the patient has interproximal restorations, we need to see the restoration margins. We need to see where the healthy tooth structure meets that restoration. So this is a guide that our students watch and look at and refer to when they're taking radiographs. This just gives you an idea of where you want your bisecting to be in the centering of your film when you're taking the different radiographs. That's something you need to keep in mind. If you're using a hard state sensor and your software kind of cues you through the different aspects of the mouth and the dentition to determine which radiographs you're taking, make sure you're centering and aligning the proper teeth. That way you're getting the areas that you need to focus on. If it's a maxillary premolar, you got to make sure that you're centering up your receptor over the premolars and making sure that you're capturing the canine, the distal half of the canine. So bite wing radiographs, as many know, we can take them both vertical and horizontal. Here is what it's going to look like when we're taking a horizontal bite wing. Keeping in mind what we're trying to do is we're trying to get either our hard sensor or phosphor plate parallel to the lingual surfaces of those maxillary teeth. So we place it down in the mandible, but we want to make sure it's nice and parallel to the teeth. Then we bring in our cone and we try to get the front half of our cone parallel to the film. If you're not using an XCP, this is especially difficult, but very critical. Right now, we've got those XCPs that help guide us. But again, we have to keep in mind that that just guarantees that our beam hits the sensor. It doesn't necessarily take into consideration that horizontal angle to get the contacts open. So these diagrams show you the horizontal angle that's required in order to get the beam to cleanly pass between these contacts. So here's the sensor. We've got a nice narrow arch, and here's our cone. If you can imagine your beam traveling through that cone and striking that sensor, is that contact, is the contact open where that beam can cleanly pass? Or let's say you've got the arch that has some significant rotation, like down here. It's going to take 2 separate bite wings in order to open up the contact on the distal of this premolar as it would to open up the contact on the distal of the second premolar. So if ever you're taking a bite wing and you realize you've got a pretty good overlapping contact on one of them, what you need to do is then go back for the retake, have that patient open really big. Look at that contact from the occlusal surface. Imagine if you were going to put a piece of floss between that contact and keep it straight, that would be the horizontal angle by which your cone needs to go and the beam to pass between those two teeth. Not only is when you're taking bite wings, are you going to get every single contact open. If you're using a solid state sensor on bite wings, pay close attention and see if you're capturing the distal of that canine. Oftentimes it's a real challenge because the sensors are so bulky and the palate starts to drop down that it just simply, when the patient closes, that hard palate shoves that sensor posteriorly, missing the distal of the canine. So diagnostic images. It's real important that you be able to recognize if an image is going to be diagnostic. Here we've got two bite wings. We've got our premolar bite wing and we've got our molar bite wing. So what we're looking for is the contacts, making sure that those are open, that we can see the margins clearly of these restorations, seeing where that natural tooth structure meets that restoration. Because many of us know that sometimes patients believe once a cavity has been replaced with a restoration, that tooth will no longer have any problems. But we know that if plaque is left in those areas and bacteria is left, that the patient could end up getting a recurrent caries up under a restoration. So it's important that we capture those margins on our radiographs. So the contacts, and then we're looking for bone levels. So we want to make sure that we can see all of the bone levels, which we do here. Now we've had the student go in and take PAs. And now we're noticing that here on this patient's lower left PA of number 20, we're now seeing what looks to be a vertical bony defect. That's another thing we always have to remind ourselves. When we're taking radiographs, we are simply capturing a two-dimensional image of a three-dimensional area. So there will be some information that we just can't quite capture on a radiograph. But that's why it's important that we capture these areas at different angles. And that's why we use bite wings and PAs together collaboratively to view the different areas of the teeth at different angles to see if there's any pathology that we miss. Because our bite wing up here showed us the bone levels, but we weren't able to see this bony defect right here, plus this large map calculus. Now here's PAs of the upper left quadrant. We've got our premolars and we've got our molar. One thing we noticed right off the bat is this radiolucency at the apex of number 13. That's a premolar. Why could we not see that in the premolar PA? Well, there's a little bit of a remnants of the radiolucency there, but the angle that we came up for the molar was the one that captured it at the angle that showed us where that area, that loss of bone was at. So that's why it's important that every radiograph we take is going to provide some key information about this patient's health. Technique for panoramic radiograph for patient positioning. We're not going to go into a great amount of depth about the panoramic, but the main gist of it is you know, with those machines, is you just have this invisible focal trough space in there, and you're trying to position the patient's mouth so that it is within that focal trough and that we don't have any distortion of the teeth. So we're looking to see that mid-sagittal plane is nice and vertical, well centered between the eyes, down the bridge of the nose. We're watching for that Frankfurt plane that we just visually draw a line between the tragus of the ear and the infraorbital process right here. And we want that invisible line to be parallel to the floor. But another thing I like to tell my students as well is when you've got the patient biting on that bite block, have them smile real big and look at their occlusal plane and adjust their chin so that the occlusal plane is flat to the floor. That way, when you look at your panorex, the teeth are nicely laid out, separated. We don't have overlapping of the roots. We can see the T and J fully. We can tell that our patient is centered left to right, because remember, when it comes to panos, we want symmetry. We want there to be as minimal distortion as possible. So we want to see that our mandible and our posterior teeth are about the same width from the left to the right. We want to see that those anterior teeth look of normal size. So we know that that patient is not too far forward in the focal trough or too far back on that bite piece. We want to see that the occlusal plane is flat to the floor or maybe a faint smile line. We don't want to have a reversed smile or an excessively happy smile. We can see the hyoid bone down here. We can see their cervical spine right here and the hard palate, as well as the ghost image of the hard palate. In this pano, we can see that the mandibular condyle on the left side is not visualized. If we look closely at the occlusal plane, we can see that the patient's chin was slightly elevated, causing a slight frown of those anteriors. Had we brought that patient's chin down, it would have brought the TMJ and the condyles upwards and into view. If the patient is having issues with their TMJ, this would be an issue and we would want to re-expose. If you notice this radiolucency down over here, that's coming up from the neck area up into the oral cavity, that is the patient's oropharyngeal airspace. I always love reviewing the anatomy and artifacts on Panorex. It's a good way to see if you know your anatomy. So we've got our mandibular condyle here. We've got the coronoid process here off of the anterior part of the mandible. So this radiopacity right here would be the patient's soft palate. Right here, this white mass beneath the oropharyngeal airspace would be the tongue that we will have had the patient raise up to the roof of their mouth. If you find that you're having an excessive amount of burnout because of the airspace up there, have your patients suck on that stick like a straw, and that helps get the air out of their mouth, and then you won't have that radiolucency that kind of burns out the roots up there in the maxilla. If your patient is too far forward on that bite piece, it's going to bring them in too far forward in the focal trough. It's going to cause their anterior teeth to be really squished together and narrow. So try to bring them back and make sure that they're at the end of the bite piece, wherever your machine requires the patient to be. Here, this white linear mass, this vertical mass right here, that is going to be a ghost image of the patient's cervical spine. Nice view of the hard palate, the orbit up here, the maxillary sinus right here. Here we can see that the mandible on this patient looks a little bit wider on the left than the right. They may not have been perfectly centered. They may have been just slightly tilted and turned to the right or left sides. Here we've got a ghost image of the inferior border of the mandible. This right here, if you can make out, this is a soft tissue line. This is their earlobe. Here's their zygomatic arch. So one of the students brought this pano to me the other day. Patient positioning is not too bad. We've got a little bit of a reverse smile. Could have had that patient bring their chin down just a tiny bit. That would have brought this mandibular condyle more into view. But what do we notice about this right here? That would be the patient's mask. They took their face mask and it had the wire for over the bridge of the nose, and they just simply lowered it down to their chin. So make sure that your patients are fully removing their masks. Yesterday, a student brought to me some bite wings, and it had what appeared to be a lingual arch wire. And when they showed it to me, we were looking at it. We were looking at previous x-rays, and those previous x-rays did not have that in there. And so we confirmed, if you can see that radiopacity in the bottom, that is actually their face mask. The student didn't have the patient completely remove their face mask. They again just lowered it right here on the chin. So he didn't notice when he was coming up to do the premolar bite wings that mask was between the source of the radiation and the phosphor plate. So you got to make sure we fully remove those masks, as well as glasses, earrings, any kind of facial jewelry, tongue rings. Always got to make sure we get those partials and dentures out of the mouth. Panorex that's underexposed. Keep in mind that we do have patients, there are folks, there are ethnicities that have denser bone and denser tissue. So sometimes we need to increase that KVP, that exposure, in order to penetrate through those tissues. So your image comes back and it's bright white, it's underexposed, then you need to go in there and you need to bump up your setting. But other than that, patient positioning looks pretty good. Chin might be slightly down, could raise that up a little bit to kind of flatten out that occlusal plane. So this would be a good spot to take a little break. How about we take a 15-minute break and we will return. So I'm going to go ahead and mute and stop my camera, and we will pick back up at 10 after 10. Hi, welcome back. Okay, hopefully you've had a chance to get some breakfast and get dressed for the day. I don't know about you, but it's beautiful here in Kansas City. So let's push on. So we're going to leave it. We've left off at technique errors. So the different types of technique errors that you always want to watch out for with causing different distortions are going to be like elongation, for shortening, cone cut. So looking at elongation, here's our first image. You take your PAs, you're doing a molar shot, it pops up. This is what you see. We can see the occlusal surface of the molars. We can see bone levels. We can see the apice of number 19, but when we're looking at number 18, we can see how the trabecular pattern and the roots are actually being stretched. They're being elongated. So that vertical angulation, if these were the roots and here is our cone, the beam was changed on vertical angulation and it caused those roots to be to be elongated, excuse me. So what's happening is here on this typodont, here is our phosphor plate in this case, because the sensor won't be able to bend, causing that kind of elongation unless you have an excessive vertical angulation on your cone. So here we can see with the phosphor plate that plate is actually bending on the hard palate. So to correct that, what we would need to do is bring that film more into the midline of the mouth where the palate is a little bit taller. Gently raise that bite piece up to the occlusal surface. That way it's not forcing the bend. And then your retake is going to end up looking like this. So rather than having this curvature of the film here, this curvature of the film on the floor of the mouth here, we're seeing that we can see that 2 to 3 millimeters beyond the apice. What if we see this radiopaque artifact on an image? If you can still see tooth surface, artifacts on the other side, that is a significant film bend. It's bending towards the source of radiation rather than away from. So being that we're doing a mandibular PA here in the premolar area, it's probably that soft tissue on the floor of the mouth has caught that plate, caused it to bend. Now, we probably see this a lot, the cone cuts. With XCPs, we shouldn't anticipate seeing a cone cut, but there can definitely still be some issues that may arise causing us to have this cone cut. So if we don't get our cone perfectly aligned to the XCP, if the patient moves on us, or let's say the film, the phosphor plate slides out of the holder, or if you're using a snap array with your sensor, it's not holding down and grasping that sensor firm enough. And then the sensor, when it touches the floor of the mouth, just kind of causes it to slide and rotate. Or it could be your actual tube head. Your arm on your tube is maybe not holding it right, and it's causing the cone itself to drift. So a few things you want to watch when you're taking your radiograph and you start seeing that you're getting cone cuts. So foreshortening is the opposite of overexasperation of the vertical angulation. So rather than coming too high and pointing down, we're going the opposite direction towards the crown of the teeth, and we're actually shortening the teeth. So here is our patient's mouth, let's say, and our XCP is guiding our cone to go low and point up. Well, what's happening is we're going down below those apices and we're pointing them up. We're foreshortening the roots. So we can see here in this radiograph that we've got, this is probably the lingual aspect of the cusps, and here's the buccal, and they're not in alignment. Actually looks like the cusps are sitting almost on top of the bone levels. So we have it retaken where the sensor is standing more parallel to the teeth, and that way we're getting the cusp heights a little bit more to the same height. And now we can see, oh, okay, here's the CEJ, and it is definitely above the bone levels where it should be. We can see the roots. So that is a much better image. So now we can see that what happened was now our XCP was directly perpendicular to the teeth. So processing errors that can happen with sensors and phosphor plates. Now, the fogging you're going to see only on phosphor plates. Exposure settings can be affected on both the PSP plates as well as the solid state sensors. You can experience overexposed images as well as underexposed images. So fogging. Fogging happens when light, ambient light, ends up hitting the phosphor aspect of the plate and begins to erase your image. So as you know, when you're using phosphor plates, we put reusable or non-reusable barriers over them. When you go to remove your barrier that's been contaminated, we need to be really quick about getting that phosphor plate either into a black box or opened up within a dark room. That way your light doesn't begin to hit it. It actually only takes 4 seconds of direct light for an image to be completely erased from a plate. So you want that to happen really quick, unless you're using a scanning machine that actually erases them for you. But that's good. You're going to notice that that is fogging when you can actually see the outlines of the teeth and anatomy on the more radiopaque aspect of the foam. So here, this image was in light for a considerable amount of time. We're starting to see that there is some total erasing that's happening of the actual images. If our exposure settings are too high, we're going to overexpose our images. Now, the great thing about digital imagery is we can actually manipulate the contrasts a little bit with our software. So that's really nice. But there are definitely going to be some situations where either our unit needs to be recalibrated or we need to adjust the exposure settings because of patients' personal tissue density. So here we've got an image that is very underexposed. If our software, we can't adjust it minimally to get it where we need it, if it would require us to do too much adjustments to it, then we probably just need to re-expose that image, increase our exposure, and get a higher contrast of an image. So let's do a little technique critiquing. I'm going to display a few filmiles. We're going to go through image by image and kind of critique them as they come up. This is a good practice to do because it's going to really start training your eyes. We'll do a little bit of interpretation, but it'll train you to be able to recognize those errors right off the bat and then discern if you need to retake it. So here we've got the upper right molar area. We are seeing quite a bit of the premolars. We really only need to see the distal aspect of the second premolar, but I would guess that this is possibly a female or a person who's just got very small teeth structure because we're seeing so many teeth on this one film. Plus, we can still see that maxillary tuberosity area, and we can determine that there's no third molar there. Here's our premolar PA. Now, notice that our cusp heights aren't the same height. So ideally, we would like to try to get that film a little bit more parallel to the teeth, but we can see well 2-3 millimeters beyond the apices. Here's our canine shot. They centered up the contact between the canine and lateral beautifully. We can see the floor of our maxillary sinus. We can see well beyond the apices of both the lateral and the canine. Here is our central PA, and we can see our laterals and central incisors very nicely. We've got a little bit of overlap around the contacts, but not much. We got a little bit of burnout at the incisal edges. This is probably their lip line right here. Looks like we possibly got a little incisal fracture in number 9. The canine PA here looks good. Number 10 looks nice. Got a great PA bit, great contact of the lateral and canine centered, well beyond the apices of the canine. The premolar PA we've got here. Cusp heights, again, aren't really quite the same height, so our film is not perfectly parallel to the teeth itself. Now look at the apices here. It's a little bit more of a challenge to see if we've got 2 to 3 millimeters beyond the image, beyond the apices. If we could, we'd want to enlarge this image and really take a look at it, but that one may need to be retaken because it's real hard. We may only have 1 millimeter beyond the apices. The molar PA. Can you identify what's wrong with the molar PA? Right, we've got a pretty good sized film bend happening up over here on the patient's upper lap. The film is being pressed up against that hard, soft palate area, and so it's forcing that plate to bend. A sensor would be great in this area because we wouldn't have the sensor bending. We would just need to make sure that we had it placed comfortably for the patient, but as parallel to those molars as possible. Right molar bite wing looks good. We could have bisected the second premolar just a little bit more, but we can definitely see and visualize that molar area. We've got good open contacts. We can see the margins of our restorations as well as the bone levels. premolar bite wing looks great. We've got the distals of the canines, which are tricky when we're using a sensor. So try to watch that. Try to get your sensor as far in the middle of the mouth as you can and rotate it at that corner so that you can get the distal of the canine along with keeping the premolar contacts open. Here's your left premolar bite wing. So we can see that our contacts are overlapped. Now, if you've got a little bit of overlap, let's say maybe 50% of the enamel, as long as you don't have more than 50% of the enamel overlap, you probably don't need to retake the image. But it's really important that the dentist can see if there's any caries that's approaching the DEJ. And here's the left molar bite wing. This is a great bite wing. We've bisected the second premolar. We can fully see our molars. We can see our margins. Now here we've got a crown on 18 and 19, but that's porcelain against metal, so caries can't form there. So it's very important that we could see that margin, that restoration margin. And then we've got plenty of bone beyond those second molars, so we can see that there are no third molars. This lower right molar PA of teeth numbers 30, 31, we can see we've got endo on number 30. We've definitely got well beyond the apices of that one. But number 31, we're definitely missing those roots. As we look, we can see that the film placement was a little too far anterior. The bite block is centered up over the third molar, but the fact that the premolars are fully in view leads me to believe that when the patient closed, their cheek probably pushed the rod of the XCP anteriorly, and it guided the student to bring the cone from the front, capturing those premolars, rather than being more parallel to the molars and capturing that second molar. Lower right premolar PA looks great. We've got the distal of the canine. Can see between the contacts of the premolars, and the roots are nicely separated. Canine PA looks great. We've got the contacts open. We've got definitely 2 to 3 millimeters beyond the apices, and we can see the bone levels. They're nice too. Here are those lower centrals. Oh, as hygienists, we get so excited about calculus, but this one just doesn't have the exciting calculus on it. But we can see our contacts are nicely opened. I don't see any incisal fractures or attrition. Bone levels look nice. Great x-ray. Here we've got a canine PA. We've definitely got the lateral and canine centered up on the film. We've got good open contacts. And then the lower left premolar is nice. The bite block looks like it's a little bit too far posterior, but the beam was anterior enough. It captured those premolars, separated the contacts, and gave us some good apices. Now the lower left molar PA, they're still a little too far anterior on this one. Can't really tell where our bite piece is seated at. So the cone was actually a little bit too low, but you can see there's a pretty good cone cut at the bottom. And then we just needed to get this bite block further posteriorly. So we're centered up over those molars, because number 18 looks like it has a root canal, and we definitely want to see the apices of that to make sure that it's doing well. This one map we're just going to critique from afar. The number 2 PA, we can tell it looks like there's a little bit of elongation on the second molar's roots. So we've probably got a little bit of film bending that may be happening on that soft palate area. Oh, that's a third molar. On this premolar shot, now we can tell that we've only got 1 premolar in each quadrant, but this looks great. We got the distal half of the canine, fully can view that first premolar as well as the first molar. Here's the canine shot. We got the contact between the lateral and the canine. Would have liked it a little bit more centered, then we could see a great view of the lateral. But in our central shot, we've definitely got the lateral and central incisors with 2 to 3 millimeters beyond the apices, and the contacts open nicely. You can see a prominent little cingulum there on the lingual aspect. The canine image looks pretty good. Again, we could get that contact between the lateral and the canine more centered in this radiograph. And then we've got a pretty good sized film bend that's happening there. The upper left premolar PA looks nice. We've definitely got the canine. We've got the first premolar and the first molar area. And then our molar PA looks good. Film positioning is nice, but the cone was a little bit too elevated, and what caused us to have a cone cut of that occlusal edge. If this was the only image that we had, we may have needed to retake that one. But the nice thing is we've got a bite wing of this area that lets us see the bone levels and how bad that decay is. Now, the only thing is with this left molar bite wing, we would have liked to have bisected that second premolar, if not the first molar, in order to capture that third molar area a little bit more clearly. But the premolar bite wing looks great. Definitely got the distals of the canines. We can see our contacts, our margins. and bone levels. The right premolar bite wing looks great. We've got the distal of the canines, the contacts, the margins of those restorations, and the bone levels. The right molar bite wing, we've got more than 50% of the enamel being overlapped between teeth numbers 2 and 3. So we would want to try to retake that, change our horizontal angulation, and see if we could get that contact more open. The lower right molar PA, we do have a third molar that looks fully erupted. I can see the trabecular pattern all around that distal root. So it does look like we have enough of the apices there. We got a little bit of a cone cut on the lower right premolar, but we definitely got 2 to 3 millimeters beyond the apice there. So we're okay. We don't need to retake that one. The canine of 27, we've definitely got a great PA of that one, 2 to 3 millimeters beyond the apex. We've got the contacts open, no incisal fractures. It looks really great. The lower central incisors, we've got the centrals, but they're not really centered in the middle of the film. So the laterals, especially number 23, we're not getting a great shot of that one, but we can definitely see this radiolucency at the apex of number 24. Now the canine shot gives us a really great view. We can see that that lesion is right around the 23-24 area. And we've got the canine nicely centered. The lower left premolar PA, we only have the one premolar again. So we bisected that canine, captured the first molar nicely. And then the lower left molar PA, we've bisected that first molar. We've got our second and third molars clearly visible, contacts, bone levels, as well as 2 to 3 millimeters beyond the apices. All right, here's a new FMS. Okay, so now we're looking at the maxillary right molar PA. So here's our molar, but can you recognize this bony artifact at the posterior area? So imagine on our patient, we've got our cone elevated up high, and we're way back here. We are actually capturing the coronoid process of the mandible. So here's that coronoid process, that bony projection, and it's being superimposed up over around this third molar area. So here's our premolar shot. As we can see that the bite piece is not seated parallel to the occlusal surface, so it kind of slipped down into this empty space. Cotton roll may have been nice to have slipped into that area to help have a nice flat surface for that bite piece to be centered up on. We've got both premolars here, so we needed to come a little bit more anterior. Canine shot looks good. Got the canine and lateral contacts centered up nicely, well 2 to 3 millimeters beyond the apices. The central shot looks great. We've got the contacts centered up. We got 2 to 3 millimeters beyond the apices and the contacts between the centrals and laterals. Here's our canine for the upper left. We've got well beyond the two apices. We've got the soft tissue of the nose superimposed right here. Upper left premolar PA, kind of the same thing before. We really would have liked to have seen this bite piece more parallel to the occlusal surface of both the first and second premolars. That would have got those cuspites a little bit more similar. We would have been shooting it more perpendicularly and separated the roots a little bit more. And here's that lone standing molar on the upper left, as well as, again, we're seeing the coronoid process. So here we've got our 4 bite wings. Noticing that they're taken horizontally. We've got a few cone cuts at the bottom of a few of these films. But what else do we notice about these bite wings? Film placement isn't too bad in the fact that we've captured the distal of the canines and the premolar bite wings. And then in our molar bite wings, we captured the distal half of the second molars. So I had the students go back and retake these radiographs. And what I had them do differently was we took those bite wings vertically. If you notice in the original bite wings, we're missing a lot of bone levels around these molars, second premolar, first molar, premolar areas. So we sent them back and they retook them vertically to help us capture those areas of bone loss. Here we notice around tooth number 18 that there's a pretty significant vertical bony defect. Now, fortunately, in our first bite wing, we were able to visualize that area. However, we couldn't see anything around that upper left molar. This vertical molar bite wing is not ideal. I would have liked for them to have retaken it to capture the bone levels, but we didn't because there were no teeth in front, and the student clinician would have been able to easily probe all the way around that tooth and inspect if there was any caries or any pocketing. The lower right molar PA looks good. We've got a little bit of a cone cut at the bottom. Can see a little bit of dense areas around the apex of number 30. Could be some condensing osteitis or idiopathic osteosclerosis. But we definitely got the distal of the second premolar. Premolar shot looks good. We got a little bit of a cone cut. Fortunately, we've got 2 to 3 millimeters beyond the apices. We might be a little bit tight on 29. If we enlarge that one, we might find that we're a little bit short and that we probably would need to retake that one. We do have bone levels and we do have the contacts and restoration margins. The lower right canine, PA number 27, looks good. Don't have an opening of the contact. There might be some rotation involved, some crowding down there. If we were suspicious that there might be some caries down there, which it looks like there could be some radiolucency here on the distal 26, we probably want to retake that one. Get the teeth, the film is parallel to the long axis of those teeth, and then just find that horizontal angle that would get that beam to cleanly pass. Here's the PA of the mandibular lateral and central incisors. We've definitely got some bone loss that we're seeing. We've got a little bit of calculus going on, a little bit of incisal attrition, but we've definitely got well to 2-3 millimeters beyond the apices. The canine shot looks nice here. Can see well beyond the apices. We can see the bone level. Contacts are a little bit overlapped. Here's the lower left premolar PA, bisecting the canine. We've got 2 to 3 millimeters beyond the apices, as well as we can see the bone levels. Now, the cusp heights aren't exactly the same height, so it wouldn't be the best angle to discern where there's bone loss. Now we've got this lower left molar PA where we have that vertical defect. We've definitely got a vertical defect happening on the distal aspect of number 18, but we've got 2 to 3 millimeters well beyond the apices, and we've got the margins of the restorations. So when do you take a radiograph? You got to ask yourself, do I see what I need to see? Am I capturing bone height where I should? Am I capturing interproximal surfaces and restoration margins? Am I capturing the apices? Is there pathology in the bone or tissue, surrounding tissue areas that I don't have all of the margins? Do I see what looks to be a cyst? Do I see what looks to be dense bone? Do I encapsulate and capture the entire area? Overall, when you're taking radiographs or looking at prescribing radiographs, do you see disease in the mouth? Here we have a patient that came in for a periodic exam and 4 bite wings. We've got, first thing I noticed is this patient has had lots of restorations. They've had some implants, crowns, multiple restorations, as well as an endo. So they're going to be higher risk for caries. Then I'm looking for caries. I'm not seeing any radiolucent cariogenic areas. I'm looking at bone levels. I see bone levels that are to be expected around an implant area. But bone levels, for the most part, maybe there's a little bit of initial bone loss. But all in all, everything looks pretty well maintained on this patient. But I do notice that on that right molar bite wing, we've got an overlapping contact. Considering there are so many restorations on this mouth, if we knew that patient had any current new caries within the last year, we may decide that we want to have that one re-exposed. But if they haven't had any new caries, pocket depths have been maintained for a considerable amount of time, and the integrity of all these restorations still looks good, we may not have to re-expose this patient. So here are the periodontal chartings that we referred to determine if we need to re-expose. This is a 64-year-old female. The x-rays were current, pocket depths were current, 1 to 3 millimeter pockets, pretty darn good. So we made the decision at that point not to retake that bite wing. So differentiating between vertical and horizontal bite wings and when it's necessary. If this isn't a patient that you've seen or a patient that you treat, you're just taking the radiographs, try to look at previous x-rays to see, did they take the radiographs, the bite wings vertically or horizontally? Or when you're looking at the patient's mouth, do you notice those teeth looking longer than normal? If you're seeing what looks like recession, bone loss, then we need to consider retaking them and taking them vertically in order to ensure that we're capturing the bone levels that would otherwise be missed. When there physically is not enough film directed toward the apex, oftentimes we miss the bone levels on our patients who have periodontal disease. If you look at the difference between a vertical And the horizontal, there's still quite a bit of information that we could be missing if they have got bone loss. Here we've got this vertical bite wing, and we're noticing this vertical defect right here. Radiolucency that looks indicative of furcation involvement. They had deep pocketing and tenderness. So it was then recommended that we take a PA. A good PA, we've got the margins of the restorations. Cusp heights are pretty much the same. So we can tell that the film was pretty parallel to the teeth, and then the beam hit it perpendicularly. And then we can see any pathology at the apices, which it looks like there is. So prescribing radiographs. Some offices you'll find, and maybe even yours, has a set determinant of how often they're going to take radiographs. It's just a typical interval. Perhaps the dentist wants you to take bite wings every year. They want a full mouth every 2 to 3 years. They want a pano on every patient once a year. I'd like to see there be conversations about when patients need radiographs. According to the ADA and FDA, they came up with a format plan for ordering radiographs. Not every patient needs radiographs every time they come into the office. So I'm going to go through and read this with you. Recommendations for prescribing dental radiographs to consider. These recommendations are subject to clinical judgment and may not apply to every patient. They are to be used by dentists only after reviewing the patient's health history and completing a clinical exam. Even though radiation exposure from dental radiographs is low, once the decision has been made to obtain radiographs, it is made in the dentist's responsibility to follow the OLARA principle, which is as low as reasonably achievable, to minimize the patient's exposure. So let's say we have a new patient come in and we need to get radiographs. Let's say it's a child with a primary dentition. Before any permanent tooth has erupted, they just have their primary teeth. Individualized radiographic exam consisting of selected PAs or occlusal films or posterior bite wings if the proximal surfaces cannot be visualized. So if you've got a patient, a little one, who's got contacts that are closed, they have caries that you can see or they've had a history of caries, then determine if you need radiographs and which ones. Let's say you've got a new patient that's a child with transitional dentition. They've already had one permanent tooth erupt into the mouth. You might discuss doing individualized radiographic exam consisting of posterior bite wings with a panoramic radiograph. The pano is going to allow the dentist to see which permanent teeth have started to develop and the positions of those teeth as well as the primaries. Perhaps you want to take some bite wings, considering doing some horizontal bite wings with a size 0 or 1 of just those posterior areas. Let's say it's a new patient that's an adult with a permanent dentition or an adult with partially edentulous teeth. Individualized radiographic exam consisting of posterior bite wings with a panoramic exam or posterior bite wings and selected PA images. A full mouth of intraoral radiographic images is preferred when the patient has clinical evidence of generalized oral disease or a history of extensive dental treatment. A new patient who's completely edentulous, only an individualized radiographic exam is based on clinical symptoms and signs. So if you see something intraorally that is concerning and indicates that there could be something going on within the bone or beneath the soft tissues. Let's say you've got let's say you've got a recall patient with clinical caries or an increased risk for caries. Then consider doing posterior bite wings at a 6 or 12-month interval. If the interproximal surfaces cannot be examined visually or with a probe, if a patient's got open contacts in those posterior regions, you don't need to take bite wings necessarily, because the doctor, the hygienist should be able to easily probe and explore around all surfaces of the teeth, as well as the probing for the pocket depths. Let's say you've got an adult who is partially edentulous. Maybe consider posterior bite wing exam of every 6 to 18-month intervals. Let's say you've got a recall patient with no clinical caries and is not at increased risk for caries. You could consider doing bite wing radiographs every 12 to 24-month interval if the proximal surfaces cannot be examined visually or with a probe. Posterior bite wing exams can be every 18 to 36 6 months for an adult with all their permanent teeth. For an adult who's partially edentulous, you could consider doing a bite wing exam every 24 to 36 month intervals if they have no signs of caries or no increased risk of caries. Let's say you've got a recall patient with periodontal disease. No matter what age or how many teeth they have in the mouth, clinical judgment needs to be considered to the need for which and type of radiographic images for the evaluation of periodontal disease. The imaging may consist of, but isn't limited to, the select PAs, bite wings of areas where periodontal disease or other non-specific gingivitis can be demonstrated clinically. So if clinically you're seeing signs of periodontal disease, you have means to take or reasons to take radiographs. Let's say you have a patient who's either new or recall that you're monitoring for dental facial growth or development and or the assessment of dental skeletal relationships. The clinical judgment should be used to determine for a child what type of radiographic images are needed to evaluate and monitor any dentofacial growth or development or the assessment of dental and skeletal relationships. So if there's issues with growth, occlusion, teeth that are going to be non-present at all, then it was good to determine which radiographs you might need for that. Keep skipping ahead, sorry. So now we've got a new recall patient who we're continuing to monitor for dentofacial growth, but they are adults. Again, you will use clinical judgment as to the need for and the type of radiographic images for that patient in the monitoring of the dentofacial growth or the development and assessment of any skeletal or dental relationships. A panorex or a periapical exam could be needed to assess the development of third molars. Usually, radiographs are not going to be indicated for a partially edentulous person or fully edentulous patient to just monitor dental facial growth or development or any skeletal dental relationships. A patient with other circumstances, including but not limited to proposed or existing implants, other dental and craniofacial pathosis, restorative or endodontic treatments, treatment periodontal disease, and caries remineralization. Clinical judgment is going to be needed in order to determine the need and type of radiographic image for the evaluation or monitoring of these conditions. So let's say we've got a new patient coming in. These are the bite wings they've provided to us from a previous dentist. So I'm taking a look at these. We're going to notice that they've got multiple restorations. They've had root canal. We've got calculus on the teeth surfaces. I can see their bone levels, and it does look like they've got some initial to moderate bone loss. So I determined that we need to see more radiographs. So what else do we have? Well, they sent us a pano from the previous office. Not bad. The chin's a little bit elevated. We've got pretty good ghost image of the cervical spine here. Contrast is a little bit milky. We just don't have a great high amount of contrast. The TMJ is a little bit out of the focal trough. So we decide that we're going to go ahead and take periapicals of the remaining teeth. And this is what we get. We're missing so many teeth in the posterior areas that we decided we didn't need to radiograph those areas. We've got a panorex that allows us to see if there was any unusual pathology in those areas or any root tips remaining. So now we've got some more images to look at. Some good ones of these anteriors. I do notice that with the premolars, these cuspites are not the same. So the PAs were not parallel. The film, was not parallel to the teeth. So our vertical angulation is a little bit off on these maxillaries. We've got some foreshortening happening. The bite wings capture the bone levels. We see our contacts. We see the margins of the restorations. On these mandibular ones, we do notice that this lower left molar PA looks good. It's captured the second premolar and the first molar. Our canine shot has a decent image of the first premolar. It's a little bit foreshortened and at an angle. The lower centrals and laterals look nice. The canine PA is a little bit too far posterior, need to be placed a little bit more anterior to get that distal of the lateral. And then our molar PA, we've got a cone cut. This patient's got some endodontic treatment, so we definitely want to make sure that we retake that so we can see if there is any recurrent lesion there. So here's our new PA. We can see that there's still a little bit of a radiolucency around the apex. Could be just a residual cyst, could just be healing from when before the root canal had been done. So now we've got a more comprehensive set of radiographs to utilize. Also up here around number 14, I noticed that we've got some significant winding of the PDL. It looks like there's a periapical pathology there too. So it's really great that we got a nice PA image of that upper left area. So what radiographs do you think that we would need to order for this patient? We've got a 48-year-old male. Notice the occlusion, the alignment of the teeth, previously existing restorations. We'd want to do our perio probing to see what those pocket depths look like. I don't notice any recession. So there's no clinical signs that there's bone loss. So perhaps we would only want to consider maybe bite wings on this patient, or maybe a pano and some bite wings. We could likely get away with just 2 bite wings, 1 on each side to see those molar areas, those hard to floss areas. What if this patient comes in? Lots of PFM restorations, lots of plaque. Look at the tissues. What would we decide we want to take here? Probably a full mouth survey. That way we can see each of these restored teeth up close. We can get good bite wings and see where the bone levels are at. Here we have a 5-year-old. We've got open bite. We've got lots of caries, lots of interproximal caries, buccal class 5 caries. We would probably want to do a couple of bite wings, maybe 1 on each side, maybe some occlusal images of these uppers, or maybe some localized PAs of the posterior and anterior maxillary areas. So always take into consideration when you're taking your radiographs, does the patient need it? Are they going to benefit from taking radiographs? Or are we simply taking radiographs because it's our protocol? It's just what we do. Try to keep that in mind and have a conversation with your colleagues about that. Here are a list of some of the resources that I've used for this presentation. I hope you enjoyed it. Does anyone have any questions or comments? Because I would love your feedback. This is literally my first CE course that I have given. So any feedback that anyone has, I would really appreciate it. No questions? Well, thank you so much for attending. I hope you were able to maybe gain some new knowledge, be reassured and instilled to focus on those really important aspects of why we take radiographs and take great x-rays. Thank you.